This is a PowerPoint presentation on Lewy body dementia by Amy Popa for Nursing 341, Spring Arbor University. After Alzheimer's disease, Lewy body dementia, or LBD, is the most prevalent progressive dementia. LBD affects more than 1 million people in the United States. Underdiagnosing and underrecognizing LBD symptoms are just two of the reasons why this form of dementia is still relatively unknown to many healthcare providers. It is also why research lags behind most other cognitive disorders. LBD typically begins at age 50 or older and affects slightly more men than women. Age is considered the greatest risk factor for LBD. Parkinson's disease and REM sleep behavior disorder are both linked to a higher risk of LBD. Having a family member with the disease may increase a person's risk. However, LBD is not considered a genetic disease. There are no specific lifestyle factors that have been proven to increase the risk for Lewy body dementia. Lewy bodies are named for Dr. Frederick Lewy, a German neurologist. In 1912, he discovered abnormal protein deposits that disrupt the brain's normal functioning. Lewy bodies are made of a protein called alpha-synuclein. In the healthy brain, alpha-synuclein plays an important role in neuronal synapses where brain cells communicate with each other. In Lewy body dementia, this protein forms into clumps inside the neurons. This process causes neurons to work less effectively and eventually die. The result is widespread damage to specific brain regions and a decline in the abilities affected by those brain regions. Lewy body dementia actually encompasses two disorders, dementia with Lewy bodies and Parkinson's disease dementia, or PDD. The most common symptoms of LBD include changes in cognition, movement, sleep, and behavior. Symptoms include dementia, which is a primary symptom. It includes fluctuations in cognitive abilities. Unpredictable changes in reasoning, memory, attention, and problem solving are noted. The person may seem better one day and worse the next day. Visual hallucinations occur in 80% of people with LBD. Hallucinations are typically realistic and detailed, sometimes frightening, and can be dangerous for the person. Treatment of hallucinations or psychosis is challenging as most patients are hypersensitive to neuroleptic drugs. They may have severe reactions or side effects from antipsychotics. These effects include increased confusion, worsened Parkinsonism, increased sleepiness, and low blood pressure, resulting in orthostatic hypotension leading to falls. For movement, some people may not experience movement symptoms for several years after the cognitive decline starts. Significant movement problems include muscle rigidity, shuffling gait, tremor at rest, and loss of coordination. Balance problems may lead to repeated falls. A weak voice and difficulty swallowing may come later in the disease process. Sleep disorders are common among people with LBD but are often undiagnosed. Rapid eye movement, or REM, sleep behavior disorder, is seen in 76% of patients with LBD. It may include vivid dreams resulting in vocalizations and even violent behavior during sleep. Insomnia and restless leg syndrome are also noted in people with LBD. Changes in behavior and mood are possible and may worsen as cognition declines. Depression, apathy, anxiety, agitation, delusions, and paranoia are all behavioral symptoms associated with LBD. It is also important to note what researchers call the 1-year rule. In LBD, cognitive symptoms appear within a year of movement problems. In Parkinson's disease dementia, cognitive symptoms develop more than a year after movement problems. This is how we differentiate between the two. It is important to know which type of LBD a person has in order to tailor treatment and understand how the disease will likely progress. Currently, only a brain autopsy after death can confirm a suspected diagnosis of LBD. There are no tests that can definitively diagnose it. Medical history and exam is a review of illnesses, medications, and symptoms, and a review of cognitive and movement tests that give valuable information about the patient. Laboratory studies can help rule out other diseases and hormonal or vitamin deficiencies that can be associated with cognitive changes. Brain imaging, such as CAT scans or MRIs, can detect brain shrinkage or structural abnormalities that may indicate other possible causes of dementia or movement problems. Neuropsychological tests, such as assessment of memory and other cognitive functions, can help identify affected brain regions. Sleep studies may also diagnose REM sleep behavior disorder, which can support the diagnosis of dementia with Lewy bodies. Lewy body dementia is a complicated disease that is frequently misdiagnosed as Alzheimer's or Parkinson's dementia. All three diseases have similar symptoms that make diagnosis difficult. A lack of awareness and research makes LBD especially hard to treat. Limited information and support to caregivers leads to frustration and burnout. Continued research will one day lead to more effective treatments and possibly ways to cure or prevent Lewy body dementia.